Welcome to the Dysphagia Matters podcast. I'm Jule and with me is Julia.
Hello. Today we are joined by Professor Laura Baijens. She's a leading expert in the field of laryngology and head and neck oncology surgery from the Netherlands. Laura has dedicated her career to improving the lives of people with dysphagia and has lots of experience and insight to share in our conversation.
In this episode, we talk about the challenges that ENT specialists face when treating head and neck cancer, such as weighing survival and preserving essential functions like swallowing and speech. Laura shares insights about the collaboration between ENT specialists and dysphagia clinicians and how this partnership leads to better patient outcomes. Enjoy listening. Hello, Laura, and welcome to the Dysphagia Matters podcast. We are so happy that you are our expert guest today, and thank you so much for joining us.
Yeah, thank you for inviting me. Very honorable. Thank you so much.
So maybe to begin with, can you tell us about your journey to become a head and neck oncology surgeon and laryngologist?
Yeah, in the Netherlands, and I was actually following medical school in Belgium. You finalize your medical school and then you start your residency in ENT, otorhinolaryngology. And after that, that is a 5-year residency. Then you are still a more general ENT physician. If you want to have more expertise in a specific topic, you can follow fellowship. So I did a fellowship in laryngology for 2 years, and this fellowship ended then in my position in Maastricht, having a position as a laryngologist. That is already for 20 years now. And in those 20 years, I will tell you more about that. A lot of things happened. You also collect a lot of new experience. And 6 years ago, I thought maybe I should also train myself in a different subspecialty of otorhinolaryngology, because I see a lot of head and neck cancer patients after treatment as a laryngologist. And then I had the opportunity, because one of our surgeons left, to do a fellowship. That's a 2-year fellowship in head and neck cancer surgery. It's with registration in the Netherlands, as it is in the United States and in Canada. You need a registration to become a head and neck surgeon. So that was ended in 2018, and then I started as a head and neck surgeon.
And what does a typical day now look like for you as a surgeon and laryngologist?
Yeah, my week is a bit mixed. You have outpatient clinics in the Comprehensive Cancer Center, where you see newly diagnosed head and neck cancer patients. And that's, of course, not on my own. It's with an interdisciplinary tumor board with a lot of experts in it from different disciplines. Then you also have days that you see patients that have been treated, so they have the oncological follow-up until 5 years after treatment. And in between, you see a lot of patients suffering from function loss because they have undergone extensive surgery or chemoradiation, and they come in the outpatient clinics for laryngology, mainly dysphagia patients. Yeah, this is a mixture in my week. It's patients with function loss versus patients with head and neck cancer to be treated or already treated. And we have also in our outpatient clinic a significant number of patients with other etiologies of dysphagia, like patients with neurodegenerative diseases after stroke. Now and then patients that had neurosurgical interventions with swallowing issues after that. So it's really a nice mixture. And of course, we also have clinical patients. Patients that are on the ward that underwent head and neck surgery and also have problems restarting oral intake, or patients in the intensive care unit that we are invited to, with the intensive care unit team, take a look at how to rehabilitate function loss. But that is a very heterogeneous population, but interesting.
It's very interesting. So you see the patient at all the different steps in the time as being a patient. So from the very beginning diagnosis through surgery afterwards until the follow-ups. And that also leads us perfectly to the next question, because you've told us before that you have 2 caps that can be helpful, but at the same time also contradictory, and that's survival versus the loss of function. Could you tell us more about that? What does it mean and how does it affect your clinical work?
Yeah, that's a very good question. And that was also the reason that I started the training of head and neck oncology surgery, because we, as a laryngologist, we received many patients after head and neck cancer treatment, and you see a lot of function loss, and patients are often more thinking about their existential crisis where they end up in before they undergo treatment, because they think, will I survive? Will I be there in a few years? And they are less focused on, okay, if I survive, what is the quality of my life afterwards? Can I speak? Can I eat, drink? So a lot of patients were disappointed. They told me, if we would have known before, I don't know if I would have undergone such extensive surgery, because I cannot eat and drink anymore, or I cannot communicate well. I have to say the majority of the patients experience, that's of course from my opinion, dysphagia and not being able to eat well as a more severe handicap than not being able to communicate well. So eating is some kind of very primitive need that we all need to have a bit of quality in our life at least. So the change when I became head and neck oncology surgeon is that I think we take a better look and we listen better to our patients before they undergo head and neck cancer treatment, and that we pay more attention to explaining them the different treatment options. If you have alternatives, if you can choose between surgery or radiotherapy, chemoradiotherapy. And sometimes you see that patients are not paying attention because they are over asked. And then you also need to recognize that as a health professional and make a new appointment, that you can say, okay, this is the information. Often we hand out flyers or folders with information, and then you really have to pay attention to tell the story again. The patients really have time to make difficult decisions, what they want to do. And also more and more attention is paid to not giving extensive oncology treatment, because patients should also have the opportunity not to follow what we recommend them. So a lot of patients in the head and neck cancer population are vulnerable people with a vulnerable socioeconomic background, with having a lot of health care issues, but also mental health issues in the past. And I cannot decide what's best for them. So we try to inform them as best as possible. And I nowadays also tell them, if you do not want to have a curative treatment, that's also an option. But of course, you then also need to explain what the patient can expect when you do not treat the disease, because the disease itself will progress as well and will also cause problems in functional loss. So this is also necessary to discuss. But from my perspective as a laryngologist, before I became a head and neck surgeon, this has changed, that we pay more attention, that we examine patients better before extensive cancer treatment, and that can be a swallowing assessment as well, if you think that is necessary to select the best personalized treatment combination for these patients.
Yeah, thank you. So you've already touched a little bit on this, where or on which wards you're working, what your clinical day looks like. But what would you say are some of the most common conditions you treat in your clinical practice?
Yeah, head and neck cancer, of course, because I'm mainly having outpatient clinics for this disease, but also a lot of neurodegenerative patients, because there are not many outpatient clinics in the Netherlands, and I don't know how it is in all the other countries, that you have an interdisciplinary team taking a look at you, and that you really can assess the swallowing pathophysiology and have an interdisciplinary recommendation. So these patients also visit our outpatient clinic for dysphagia, and often there are patients from all over the Netherlands. So they have been to similar outpatient clinics in their region, and then they were referred by my colleagues, otolaryngologists or neurologists or gastroenterologists. So a lot of different health professionals refer patients to our outpatient clinic for dysphagia in Maastricht, that we take a third and sometimes a fourth look. And I always are honest to patients. I cannot solve every problem, but we are able to take a close look and to see what could be the problem. And then we have to see if there is a solution for the problem or not, or something in between.
And by taking this very close look, how do you collaborate with other dysphagia clinicians?
Yeah, that's a very good question, because I think it's something that should not be done monodisciplinary. I know I have a lot of experience with those two heads, but I think still not enough to take a look on my own. So I am very grateful of having speech and language pathologists in the interdisciplinary outpatient clinic for dysphagia, so they are present. And we have a physician assistant in the radiology department that is dedicated to our patients as well. So on the day that the patients visit, we can have a look in the interdisciplinary outpatient clinic, and afterwards they can go to the radiology department. And I think, you are together in this trajectory for the patient and also the patient himself, because they also need to tell us what they expect, what they want, how they see care. Yeah, this is the only setting or the only way of integrated care. You have a broader scope when you are together, and all the different disciplines have different points of attention. And in the end, you put everything together, and then you have to make your interdisciplinary decision on treatment, rehabilitation.
Yeah, absolutely. Do you feel that time is an issue to work interdisciplinary? Of course, it's really valuable, but then, like you said, everyone brings in their perspective, and then you need the time to actually discuss this, to exchange your perspectives. How do you feel does this work out in your clinic?
Yeah, that's the major challenge for the future. When our aging society is having more and more dysphagic patients, and this exactly as you say, you cannot, in the ideal world, you would do this in every patient, the swallowing assessment with multiple health disciplines. But I think you need a step before that, some kind of screening program, or folks in healthcare that are very sensitive and have a high awareness of swallowing issues, and that they can refer the patients to this specific interdisciplinary outpatient clinic. So in head and neck cancer, all the newly diagnosed head and neck cancer patients are screened for multiple conditions like malnutrition, dysphagia, sarcopenia, frailty, cognitive impairment. And then this is actually the same, I think, in other populations, and even more specifically, for example, for dysphagia, that you screen your patients. But even this is, I don't know how it is in the other countries, but it is still a knowledge gap, and difficult for patients to come into contact with health professionals that screen.
Mm-hmm.
Even in the more challenging diseases where you expect a higher prevalence of dysphagia.
Yeah, and be aware of, for example, dysphagia being one sign symptom that can develop during the course of the disease. So just actually receiving this information. And I realized doing interviews with people with Parkinson's, that oftentimes they weren't aware that dysphagia was something that could develop during the course of the disease. And as you just said, it's something so important once swallowing, eating, drinking doesn't work anymore. So it should be so normal, I guess, as you would inform somebody about the motor symptoms like a tremor that could or is maybe already there, that you also inform them that swallowing might become more difficult.
Yeah, that's absolutely true. And even independent of your underlying etiology, if you have head and neck cancer or you have Parkinson's disease, even then, when you inform patients about this condition that can appear, so dysphagia, they forget, because they have a lot of other issues that are, especially in a neurodegenerative disease, maybe be severe before they have really problematic swallowing issues. So they also forget. So it's also something we need to repeat, or in the trajectory of these patients, there should be multiple times that health professionals pay attention to dysphagia. I agree with you.
Yeah, it's true. Especially in the beginning, there's so much new at once, so it might be quite overwhelming.
Exactly.
In the diagnostic process and also in the treatment afterwards, what do you think is the role of the ENT specialist?
Yeah, I think the ENT specialist is a very general terminology because you really need an ENT specialist that has dedication to swallowing problems, because I think there are also a lot of ENT specialists that are experts in other sub-disciplines within the ENT field. And you often see that patients are referred to the ENT doctor and that they do not have a dedication to swallowing problems, and that the swallowing examinations are carried out monodisciplinary or without an extensive, really in-depth assessment of swallowing physiology. And that's not good. So I would recommend that an ENT specialist should be a doctor that has some affinity, dedication to functional problems, so to dysphagia, to actually a laryngologist. That is not an officially registered subdiscipline of otorhinolaryngology, but nowadays you really can do nice fellowships to learn a lot on these topics, on voice, on swallowing. So, and the ENT specialists, especially in the neurodegenerative diseases, because that are not specifically etiologies that are seen by head and neck surgeon. So there you go more into the field of the laryngology and the otorhinolaryngologist with dedication for laryngology. These diseases are progressive. You cannot see a patient every 6 months or so, but that the patient knows, I was here, this is my diagnosis, this is the treatment I was recommended at this moment, but I know that I have a progressive disease, so probably in the future it will get worse, and then I know where I can go. And we always tell patients, this is our protocol, what are the assessments, what is the role of the assessments, and what are we going to offer you afterwards. And then they know this pathway, you can say, this healthcare pathway, and I have the impression that they come back when they need an updated recommendation. So they find their way then, and that's also good. And it can be in our clinic, but I can imagine that others in the Netherlands, for example, also offer this service, that you really do some kind of follow-up. And when we contact SLPs in the primary health network, because they often treat the patients for longer times, so the swallowing rehabilitation, for example, this is also a very important connection because they observe the patients, they have contact with the patients, often at home or in their nursing home or where the patient lives, and they can also refer patients back to us. So if it is difficult for the patient to self-estimate when he or she needs to come back, I think the primary health care network is also very important.
Yeah, absolutely. And can you maybe share an example of a patient where the teamwork between you and other ENT specialists and dysphagia clinicians made a big difference in patient outcomes?
Yeah, this is what I addressed before, that if you have two gaps, two heads, you look at patients in a different way. And what we nowadays do is, if you have a certain cancer stage in laryngeal cancer, you can have radiotherapy as the primary treatment, or chemoradiotherapy versus total laryngectomy. And the chemoradiotherapy is called the organ saving therapy, so you can keep your larynx, but this does not mean that you will keep function. So sometimes patients already have major function loss. They are enormously hoarse. They cannot speak well anymore. They have swallowing problems, mainly aspiration, because of an afunctional larynx, because the vocal folds don't close anymore because of the tumor. And then sometimes they need a tracheostomy surgery, emergency surgery, because they also cannot breathe. And then still you can do radiotherapy or chemoradiotherapy. But this is already an afunctional larynx, so then the risk is there that it even gets worse afterwards, and that you have a larynx with severe aspiration, having pneumonias, not being able to swallow. And if you have received radiotherapy, you can still do a total laryngectomy if patients have severe aspiration, but the tissue is very intensely radiated. And this tissue, you cannot take everything away when you take out the larynx. There are still pharyngeal constrictor muscles, muscles of the tongue, and they can all be radiated. So the fibrosis and function loss, and also the sensibility, so the sensorial feedback from your neopharynx, can be affected by radiotherapy. So then you cannot aspirate after a total laryngectomy, but you still have major swallowing issues. So, and for patients, it's very difficult because if you explain a total laryngectomy, no one immediately says, okay, I'm going to do that. But by telling them how it is after radiotherapy and how the function of the larynx and the pharynx is at the moment before the start of cancer treatment, patients can also decide with the head and neck surgeon what way to go. If you go for surgery, probably having much better outcome functionally in the end than radiotherapy on the larynx that is already afunctional. And if you decide to do surgery afterwards, it will not improve. So I think this has changed. And it's the same for advanced stage oral cavity tumors. If patients have large tumors in the tongue of the floor of the mouth, they need really extensive surgery and often followed by chemoradiotherapy. And sometimes the tumors are so large that we say, okay, this is not compatible with quality of life because we have to take out almost the entire tongue. Then it is not done anymore in the Netherlands. But if you have patients that come for the first time and they have large oral cavity tumors and they still eat and drink and they tell you, I don't aspirate, then the question arises, maybe I should take a look, do some swallowing imaging to see how the patient compensates now, because this grows slowly, this cancer, and patients adapt. And if you do not do surgery in oral cavity tumors, the prognosis is quite bad. So you can do chemoradiotherapy, but the survival is less than when you do primary surgery followed by radiotherapy or chemoradiotherapy. So then you already decide that you will make the prognosis worse if you do not do surgery. But in some patients, probably it will not beneficial to do surgery because they end up with nil peros. They cannot eat and drink anymore. These are patients, I think, that it can be of added value to do an extensive swallowing assessment with video fluoroscopy and with fees, and also maybe an eating assessment by the SLP to see what patients' natural eating behaviors are, because this can also make them successful in eating despite the fact that they have this very advanced tumor in their oral cavity. So this has changed because you take a better look, you could say, at function, loss, and also patient variables like cognitive skills. Do you have a good network around you as a patient that can help you to rehabilitate at home? Because if you are completely on your own, it's also very difficult. So you have to take all these factors into account. But this has improved. I think this is really something, especially when you do it together with all the other health professionals that play an important role in dysphagia care. It has improved.
So it's not only about thinking about survival, but also what the survival would look like later on, what the quality of life would be, and how big actually the function loss was or will be. And then also, if I understand you correctly, for example, swallowing assessment, pre-tumor treatment and then post-tumor treatment. So involving all disciplines from the very beginning to make a multidisciplinary approach.
Yeah, exactly. I think that's an important framework, you could say.
Yeah. And is there something in your ideal world, or maybe you already have the ideal world, how dysphagia clinicians and ENTs could even better collaborate to provide holistic care for patients? If maybe you had different resources, would there be something that you would change?
Yeah, it took many years here in the clinic to establish a framework where all the health professionals from the different disciplines could give their input, you could say, on diagnostics, screening or diagnostics, and that we have a integrated recommendation to the patient. Yeah, I think this is the most important thing if you are starting in your own clinic to build up some kind of framework or collaboration, that you should start from the beginning with all the stakeholders that you need, that they are involved from the beginning. Because as medical doctors in particular, we have the, how do you say it, that's meant to be from a good intention, but it is in the end not working out effectively. I think you need to engage with the other health professionals involved in dysphagia care. So the speech and language pathologists, the dietitians, probably the rehabilitation physician, because it's not only the swallowing organ that is affected, often other physical issues that also play a role and may worsen swallowing function. If you want to start something up, you need to sit and probably multiple times together with these colleagues and ask them, what do you do? How do you measure this? Is this a validated measure? What is the reason that you do this? Could you maybe change if we find another assessment that is having better sensitivity and specificity, or other reasons that you can name to change an assessment type? And if you do that from the beginning, everyone can look for his own domain, what is in the literature, what's even maybe better than what we do. And in the end, it should also be feasible. We can do the perfect examination that will take 3 hours, but you only have 20 minutes. Then you also need to make a decision what you want to know in a short period of time. And I think if you sit together, in the end, it will take some time, but then you can really establish a framework that fits your clinic or your population. And I know in conferences internationally, we are always striving to have the perfect validated measurement tool. And often these studies have been done in specific countries, monocentric or multicentric if we are lucky. And then you have your recommendation to use this or that measurement. But if you translate that to another culture, another country, another continent, it's completely not feasible. So I think, it's difficult to find out the wheel every time, but it strongly depends on what are the resources you have in your country, in your clinic, what are the health professionals trained for, because not in all the countries we have the same level of training. So this is something that I learned in my clinic, in my history, that you need to invite the others before you decide some kind of framework. You cannot top-down decide for others what they should do. So this is, I think, important.
Yeah, absolutely, very important. And besides the people and the healthcare professionals that are then actually working, have there been any recent advances or innovations in technology, for example, in ENT care that you are excited about?
Yeah, in our own clinic that we started, and this was such an example a few years ago, screening all the newly diagnosed head and neck cancer patients for dysphagia, malnutrition, sarcopenia, and frailty. And frailty is a very broad construct, so cognitive frailty, but also physical frailty. And in the past, it was like a gut feeling. If someone had a high BMI, then he was not malnourished, so you did not have to do a screening. But we learned that it is not the BMI, but body composition that is important, especially when you perform extended surgery and you have risks of wound healing complications, etc., and also patients that need to be rehabilitated by the SLP afterwards, and you do not do a cognitive screening before, it can be a disaster afterwards because you cannot rehabilitate some folks. So this is really something I'm really happy about, that we did it, as I just explained, with from the beginning with all the stakeholders, and we made this framework. Dysphagia is one of the important domains that we screen for, and then all the other domains are intensely connected to dysphagia, so you cannot ignore them. So that's something I really am happy with, and we can also do that after treatment so that we follow the condition of the patient afterwards to get better functional rehabilitation. And I don't know if you heard this, but there are studies in the Netherlands. It's by Professor Zuur. She started incision study, and now a second study hopefully will start, and it's with neoadjuvant immunotherapy for patients with advanced head and neck cancer. So people with large tumors in the oral cavity, but probably in the future also in other sites of the upper airway, that they start with immune therapy, nivolumab, ipilimumab, other medication that will make tumors smaller, or that was something that they did not expect, even let tumors disappear. And so the protocols were, we do this neoadjuvant treatment, and then afterwards patients receive surgery, and even maybe afterwards radiotherapy after surgery. But then there was a significant number of patients that even did not have a tumor anymore and did not want to undergo surgery. And that's actually a good decision, because if you, as a head and neck surgeon, don't see the tumor anymore, it's difficult to decide where you are going to take a piece of tissue in the oral cavity. So this was really something that I'm very excited about. And I think in the next study, it will be the next step to see if other tumors, and some bigger sample size, if patients can be treated without surgery, patients that actually had the best prognosis with surgery, even maybe in the future can escape from surgery, because this is probably even giving a better functional outcome. But this is going on, a project we don't know at the moment, and I always make fun of it. I say in the end, now I did this fellowship in head and neck cancer surgery, and just before I retire, probably I only am there to take a biopsy of tissue to prove that it is cancer, and then the patients get a pill. And we are not going to do extensive surgery anymore, but probably it will take some extra years.
Yeah, and then talking again about survival and loss of function, it depends on what your focus is going to be, what you want to do.
Exactly, another challenge.
Yeah. Well, that really does sound promising and exciting. So yeah, let's see what the future brings. We've already reached the end of our questions. Do you have anything that you would like to share with our listeners as a take-home or take-to-work message?
I think it's a lovely profession, being involved in the care for dysphagia patients. A lot of folks have all kind of other problems, and dysphagia is probably one of the symptoms in a larger disease complex. And it makes a difference for people when they can eat it and drink, even if it is not normal like it was before. But this is something that I get a lot of satisfaction from. Because if you can start eating and drinking again, it's also endorsement for the patient to try to rehabilitate from the overall disease that he or she is suffering from. So it's often, if you can start some oral intakes, often pushes the patient to push his own limits, to go further and to try to rehabilitate even beyond what we expect. So that's what I like very much in this profession. And what I can say in general is that you need to find collaborators. And I know in some countries this is difficult, because historically dysphagia was put under a certain medical discipline, for example, the otorhinolaryngologist. And they think it's not beneficial to learn endoscopic swallowing examinations to other disciplines, not being otorhinolaryngologist. And I think this is fear that is not necessary, because if you start with teams of SLPs or SLPs with dietitians or geriatric physicians, you can also organize a safe and well-organized assessment of endoscopic swallowing examination, and the ENT will get even more work. All the patients that have coexistent abnormalities in the upper aero digestive tract will be referred to the otolaryngologist anyway. So you get more work. You don't have to be scared that you will see less patients if others are going to do an endoscopic swallowing examination. So if you have especially new young ENT doctors in your ward, it is interesting to start the debate, as I told you before, that you sit together with different stakeholders and try to make a new start, to find a framework that is fitting your clinic. And that can also be a more dynamic framework, that you have other health professionals that perform a FEES examination next to the ENT doctor. So this is what I hope will change, because it will make a big difference in the accessibility of dysphagia care for patients.
Yes, absolutely. That's a wonderful statement or recommendation to end this episode, I think. So big thanks to you, Laura, for taking the time and sharing your knowledge with us.
Thank you for the invitation, and it was my pleasure.
Thanks so much for listening. We hope you enjoyed this episode. As always, if you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram @DysphagiaMatters, on Twitter @DysphagiaPcast, or visit our website at dysphagiamatters.org. Take care, everyone.